So relapsed refractory amyloidosis is a very interesting population because we didn't have any good criteria to define who is relapsing. There are some centers that prefer to treat patients before they truly develop organ progression, and there are some centers that think that you might have organ progression close to the time that you get the hematological progression. The reality is that you have to individualize that assessment. So the first challenge is identified when patients truly need the treatment. And the second challenge is to define what is the treatment that comes in. Now that we have CyBorD Daratumumab as the first lines of therapy, then the question is how we're going to treat those patients that are actually progressing after Daratumumab. And then there is an enhanced proportion of patients with translocation 11-14 that we could potentially use an BCL2 inhibitor, so we can use venetoclax. But as it is right now, venetoclax is not yet approved for patients with light chain amyloidosis, and the hope is that through clinical trials we might be able to show that there is responses and that patients actually do better. But as it is right now, we just do compassionate access program for venetoclax in centers that can get access to that, but there is a challenge in terms of what we can use. So in the past, we used to get access to the drugs that we normally use for myeloma, but because nothing is approved in the relapsed refractory setting, we try to just extrapolate the results that we see with myeloma and try to use it with patients with amyloidosis of light chain. The reality is that the frequency and the dosages might be a little bit different, and patients with amyloidosis of light chain do have a clone that is smaller, so the treatment may actually be